Very good morning, ladies and gentlemen, and a warm welcome to everyone attending this week's CPT program organized by the Sri Knowledge Academy. Just before going into our routine program, I would like to remind you all about the housekeeping of today's webinar. As you all heard of the top tips from the Sri Knowledge Academy, we are not entertaining any attendees after 9:45 a.m. today. Moreover, we would like to ask all of you to switch off the mute your microphones, and also do not start videos throughout this webinar program as a courtesy for our lecturer. And also, in case of any unwanted log off due to power failure, we encourage all of you to write down the contact number of our contact persons at Sri Knowledge Academy, and please do call them if you have lost connection in the middle of the webinar. Today, our topic covers the fundamentals of histopathology and what every MO should know. Dr. Chandika Epitakadua is our guest lecturer today, and he is a consultant histopathologist at the Base Hospital Puttalam and also Colombo East Base Hospital. I sincerely invite Dr. Chandika Epitakadua to continue the program. Sir, we really appreciate your willingness and joining hands with Sri, and we do wish to work with you in the future also. Sir, please do us honor and continue this CPD program. Thank you very much.
Very good morning to all of you. Today, I am going to discuss with you some of the basics in histopathology. Actually, our topic today is what a medical officer should know. But I would like to rephrase it. It is not what a medical officer should know. It is what an ordinary medical officer should know. So in this picture, you can see a surgeon is doing a surgery here. And at the end, you can see a histopathologist reporting. And in the middle, in between these two scenarios, you can see a lab procedure is going on. So where you are right here. So we are going to discuss about things which you need to know, not what the things histopathologists need to know. So this is all about the basics in histopathology, what an ordinary medical officer should know. To start with, there are two disciplines or two subcategories in histopathology. That is the cytology and the histology. In cytology, what we get is about the cells. So you know how we get cells from you. It can be any body fluid. It can be pleural aspirations. It can be peritoneal aspiration. It can be some cytology which comes from FNACs, fine needle aspiration cytologies, or it can be bronchial washing, bronchial brushing, or any sort of cytology or cells, body fluids you get from, you send us for cytological examination. So what we usually do is we look at the cells and how they have been arranged, whether they are in clusters or whether they are individually scattered, and how the individual cells are arranged in the clusters. At the same time, the morphology of these cells, whether these cells are big or small, whether the nucleus is big or small, or the chromasia, that means the color of it, and the nuclear membrane, and the pattern of chromatin distribution. Based on these things, we are going to comment on the cytology report. In addition to that, we are going to comment on the other cells which are distributed in the other areas of the smear, as well as the background things. As an example, there may be necrotic material or some inflammatory cells which are distributed around these cell clusters. So these are the usual things we comment on in cytology. So the cytology is a little bit too basic, let me say. But when it comes to histology, we can see a lot of things. We can see how these cell clusters are arranged in a form of a tumor or some lesion. and how the background things, the other components of the tissue is reacting towards this. So the first picture shows you the cytology of breast cancer, and this is the histology of the breast cancer. So you can see how these cells are, the cell clusters are arranged in the tissue, and what sort of a response the surrounding tissues is showing against the invading cell clusters. So we can see, we can comment on a lot of things. A lot of additional information can be given to the clinician by the histology report in comparison to cytology. And at the same time, I'm going to discuss you briefly about the things, what we do in the histology labs, because this is very important to you in order to know how the things are going on. So if we do a cytology, we do fine needle cytologies, aspirations, and after that, we make a smear, and then we fix it. Then it will be accompanied with a request form, and then we stain it, and then the slide is ready. So really speaking, we can issue a report if you really need it in 1 hour's time. From the time of fine needle aspiration, it should be 20 minutes period for this step, the fixation to happen, and the staining and preparation of the slide and reporting will take the rest of the time. So in 1 hour's time, we can type it and issue it. So if you really need, we can issue the report in 1 hour. So the process is relatively short. But when it comes to the histopathology, that means histology, when we do a surgery, and when you send us the specimen with the request form, put in formal saline, it takes time for the tissue to get fixed. As you know, the bigger specimens take more time for fixation. The infiltration rate of formalin, or we call it 10% formal saline, is 1 millimeter per hour. So it takes a significant time for formalin to reach all the cells and fix it. So when the sample comes to the lab, if the specimen is fixed, then we take it for the cut-up. We describe it macroscopically, and we take relevant tissue sections, and then it will be put into this machine, which we call the processor. And there, what we do is we take water component out from the cells, and we put paraffin inside the cells. And then the dried or the paraffin impregnated tissues fragments, what we do is we embed them in paraffin, and it will be fixed to a microtome machine, and this lace-like structure will come out, because we take very thin sections, about 3 to 4 micrometers, and then we take this, it is put into a water bath, and what we do is we make these slides. Then the slides will be stained, and it will be prepared for the histopathologist, and we report it. So you can appreciate, I suppose, this is a longer procedure. So it takes time. So it will take 1 or 2 days for the report to come in Sri Lankan setup. But based on the other issues in the lab or the infrastructure facilities available, the time can differ. So the earliest which you can get a histopathology report for histology section, that means for a biopsy, varies with the lab facilities available, and it can vary from usually about 2, 3, 4 days like. So what we do is we use 10% formal saline for histology specimens. So the selection of the container and the fixatives is very important when it comes to histology. Because sometimes we have seen in some of the units of hospitals, we have been sent the histology samples saline. I think this is by mistake because some people call this formalin, some people call this formal saline. So the person who has sent this the histology specimen in saline may have thought, so this is sort of a saline. But we have to appreciate that this is a diluted solution of formalin, and we call it 10% formal saline. So usually the saline solution, the formal saline solution, is prepared in the lab and provided for the clinician. It may be available in the theater, where the theater sister is responsible for the process, and it may be available in your ward setup. So 10% formal saline is what we need for histology specimens. So other thing I have to stress is that this should be sent in a proper container. I think from the medical student days, you may remember the properties of a good container. You may remember the adequate size of it, that means the volume, and it should have the proper lid where there's no room for leaking, and so many good criteria that should be included in the container. So I am very much interested about the volume of it, because I have seen some of our SHOs or maybe the surgeons sending samples in very small containers. What is going to happen is when you take the sample at the time of the surgery, it is soft. But when you put it in formal saline, it becomes hard. When it becomes hard, and when the container is also smaller, sometimes it will be very difficult to take the specimen out without damaging it. So sometimes we have witnessed that we have to break the container. If it is a plastic one, which we encourage, we have to cut it open. Or if it is sometimes, if you send it in a glass container, so we may have to break it. So it's not going to be a good thing for the specimen as And at the same time, there are things which you have to remember when sending histology, cytology samples. Label at bedside. You have to label the specimen at bedside in order to avoid all sort of confusion. And at the same time, don't keep in the ward and send it to the lab immediately. And if unable to send immediately until you dispatch it, keep it in the fridge. And especially if you are doing FNAC samples, you have to remember, refer the patient to us. We would like to do the FNACs by ourselves. And there's enough research done onto this. And if you Google, you may find out that there's more chance of a pathologist reporting a specimen as inadequate sample if somebody else has done the aspiration. If the pathologist himself or herself did the aspiration, there's more chance for him to think that the specimen is adequate. So that is because there's a more clinical approach, and the histopathologist has also can get the clinical background into his process of thinking. So it is going to be good for the patient at the end. So if you have got a patient, don't try to do the FNACs at your lab, at your ward, and please refer that patient to us. But when you are referring, you have to provide us the adequate clinical information. At the same time, the radiological findings. If you are sending us a patient with a goiter, you have to definitely send us the ultrasound scan findings of the neck, because we should know from which nodule we are going to aspirate. If there's a suspicious nodule, the aspiration should be done by that. Otherwise, we will go by the most prominent nodule, and the dominant nodule will be aspirated by us. So there may be some other nodule which is going to be missed. So it's your responsibility to send us only the patients with who have undergone the radiological investigation. So at the same time, OPD is going to be, FNS is going to be an OPD procedure. So no need of hospital admissions. I have seen in some hospitals where the patient there had been a habit of admitting the patients for FNACs. So there's no such a need. Just send the patient with the appropriate referral and the clinical, and the radiological findings to our clinic. And if you are in need of a really urgent FNAC report, we can issue the report in 1 hour's time, but you have to talk to us beforehand. Otherwise, we won't be able to do it. So when you are going to interpret the cytology and histology reports, there is going to be either benign or malignant. The malignant one can be very invasive ones, or the pre-malignant ones, or borderline cases. So depending on the structure of the body, where you find the lesion, this can differ. So what we usually do is we send these reports in different colors. The paper will be maybe white in benign, and it may be a colored one in malignant, pre-malignant, and borderline cases. So that is the easiest way of differentiating between these things. And at the same time, if you want any clarification, you are free to come to our lab and ask us what is the meaning of this. So if it's a malignant, we will tell this is malignant. And if it is pre-malignant, we will tell that you have to remove this because this is going to invade the body. And if it's a borderline, we will tell most probably, this may lead to metastasis or whatever, and the patient needs follow-up. And margins, when it comes to margins, which we usually tell is about, depending on the cancer, it differs. But if the tumor is very close to the margin, it's less than 1 millimeter like, or maybe 2 millimeters in some of the instances, we consider this as involved. But since we can't see that much clearly, what we will tell is the lesion, the tumor tissues are present at the margin. So that itself means there's involvement of the margin. Or if the clearance is less than 1 millimeter like, so it should be considered as involved margin. At the same time, I am going to share you some information about the follicular neoplasms, about in the neck, that means in the thyroid. And there can be follicular adenoma and follicular carcinoma, because the thyroid is made up of, naturally it is made up of follicles. And it comes to the follicular adenoma, there will be apparently abnormal accumulation of follicles, but it is well defined like this. There is going to be a good capsule around it. And when it comes to the follicular carcinomas, you are going to have a invasion. This is the capsule, you can see it. This is the site of the lesion. So you can see like a mushroom coming out. This is the site of follicular, invasion, site of invasion, the capsular invasion of the follicular carcinoma. And at the same time, you can appreciate this is a blood vessel here, and the lesion is here. This is made up of follicles, and it is invading, and tissues can be seen inside the blood vessel. So we should have either capsular invasion or the vascular invasion in order to tell that a follicular lesion is malignant or not. So obviously, we can't do it using the cytology. If we mention something as a follicular neoplasm, and if we ask for surgical intervention and to get it out in order to assess it histologically, so this is the basis. We need to see the capsular invasion or vascular invasion in order to differentiate it from a follicular adenoma or from a follicular carcinoma. So very important to assess it histologically. And there are some ways which we can save money for the country. The cost of histopathology is huge. Sometimes it's in thousands. So when it comes to immunohistochemistry, where we do for the receptor affinity, so that is going to be in 100,000s. As much as I know, the ERPR, HER2 and Ki67, that panel, which we usually do for the breast, is going to cost more than 100,000 in the private sector. So the same cost will be in the government sector as well. There's something called free health. This is called the government funded or the public funded health. So we have to always try to save money for the people, for the country. And in order to do that, what you have to do is, if the patient had expired, please inform us. Sometimes they may be very critical at the time of the surgery, and patient may have died. And without knowing that the death of the patient, we may go ahead and do a lot of unnecessary immunohistochemistry in order to differentiate or type the malignancy. So that is going to be not useful for the country or the patient. So please inform us if the patient has already expired. And at the same time, if the patient has been transferred to an oncology center, please inform us, because it will be faster for the patient to get it done from that oncology center itself than it being couriered to that place where the immunohistochemistry is done. So from the side of the patient, the report will come to the patient in a faster channel if we do it at the place where the patient is being followed up. So if the patient has been sent to the oncology center in the country, the patient probably may be able to do it from then and there. So we are happy to provide the wax blocks to the patient. So it should be asked from us with a referral letter. So we will issue the wax blocks to the patient. So a patient can take it into his place, his clinic, and get the things done from that hospital. So that is easier for the patient. At the same time, we have seen about 1/3 of the reports are usually not being collected at the maybe at the histopathology lab itself, or sometimes maybe at the level of the clinic. So this is not good. This is going to be a wastage of time, our time, as well as the money of the country. So please collect all the lab reports, right? It's going to be your responsibility to send somebody or to come personally to our lab and to collect the reports and uh, use it for the patient treatment and patient management in the future. So if there's specimens, or no, sorry, if there are reports which are being accumulated in the clinic at the clinic level, so please try to hand over the report to the patient, and please allocate somebody for this purpose in order to contact the patient and hand over the reports. So these are basically the things which I wanted to share with you. So I am ready to answer any question which can be which comes into your mind. So being a histopathology is very difficult. Sorry, don't want to discourage somebody coming to the field. It's not going to be difficult. It's going to be a different field where the histopathologist is totally in charge of the report. Unlike in other fields, maybe hematology, chemical pathology, or other lab specialties, or the clinical specialties, where the usual SHOs and the uh, other people also can issue the reports or can see the patients at different levels and issue a diagnosis for the patient or involve directly in patient management. But when it comes to histopathology, the histopathology is supposed to be responsible, and his signature is carried in all the slides, all the specimens, all the lab reports. So he is the one who has seen all the slides which has been produced in the histopathology lab. So because of this reason, it's going to be a little bit, boring to you if I try to discuss about the cellular morphology and the tissue structures here. So it's not going to be good, I suppose. Because of that reason, I decided to share only the basic information which are relevant to you. But that doesn't prevent you me asking questions. If you ask a question, I will give the best possible answer. If I don't know the answer, what I can do is I can go back to literature and find it out and let you know. That is very simple. So please don't hesitate. Please ask questions where I am going to answer to the best of my ability. Thank you.
Thank you very much, sir, for giving us that exciting and very comprehensive lecture. So there are a few questions about pap smear preparation and also about transferring the pap smears from the ward to the lab. What are the antiseptics that we can use, or is there necessity of using antiseptic when doing pap smears? Is one question. And another question is, how does the pap smear samples must send to the lab?
There are two parts in that question, I suppose. The first part is, what are the antiseptics that can be used? Usually, what we advocate is use normal saline for that purpose to clean the area, especially if you clean that area with Betadine or some other antiseptic. Better to reuse normal sterile saline, and clean the area once again. Because we have seen the betadine itself can give some artifacts or the coloring in the pap smear. So the best is going to be use the required antiseptic at your level, which has been prescribed, and then clean it with normal saline. So that is going to be the best thing. So when you take a pap smear, it is very important to use the spatula properly and take adequate amounts to the spatula and to spread it properly. When you are spreading it, don't spread it all over the slide, because we need to put a label at one end and we need to put cover slips on top of it. So it's going to be not good if you are going to put the whole thing, all the mucus and the material which you have taken on the slide itself. Should be very thin one. The thinner the smear is going to be better. So in order to prevent a sample being inadequate or unsatisfactory, the best thing is going to be the best thing is going to be you have to provide us a thinnest possible sample, and it should be put the smear after preparing it. It should be put immediately into the fixative. That means 95% alcohol. The alcohol jar should be ready there, and there should not be anything that can dry the specimen. That means sometimes sometimes there can be the AC machine will be there, which can make the smear dry. At the same time, there can be fan working, which can dry the specimen. So that's not going to be good. Air drying is a basic issue in pap smears. So you are supposed to switch off all the machines around which can make your smear dry, and put the make the thinnest possible smear and spread it adequately and put it immediately into the specimen jar. That means 95% alcohol, and keeping it 20 to 30%, 30 minutes in the fixative is enough for the thing to get fixed. So when it is that time has passed, still you can send it as to a in that same container where it is usually practiced. Or if you don't have that much of jars, you can either take it out and dry it and put it in a different packing and send us. So no issue if you don't send it in the original container with the 95% alcohol. You have to keep at least 20 to 30 minutes for it to get fixed before removing it and the slides. So these are the things you have to remove.
Thank you very much, sir. There's another question. How much of delay that is acceptable in fixating a specimen and on sending to a lab?
Usually, what happens in the surgical setup in theaters, what we have seen is sometimes the theater sister or the person who is responsible to get adequate volumes of formal saline may not have done his job or her job. So the result is going to be there may not be enough fixatives at the theater. So I have seen sometimes the surgeon put it to an empty container where he expects others to put the fixative in. But what happens is at the time of putting the specimen into an empty container, there can be a lot of blood getting transferred. So the responsibility of the person who puts fixative inside is to put some water and wash the specimen a little bit and to remove unnecessary blood, and then take it out and put it once again to the container and put the fixative without it containing blood. And at the same time, what you have to do is you have to put the fixative then and there. Because once the body, the tissue has been removed from the body, it all the blood coming into the organ will stop, and there will be no oxygen for the cells to live. The cells will die. With the death of the cells, what will happen is they will undergo the routine or usual autolysis, because We have got lysosomes in the cells. They contain various enzymes. They will come out and destroy the cell. Because of this destroyer, what will happen is the microbes which are around also will come into the skin, and the whole thing will get putrefied. If you fail to put the formalin in time, we will get a photolyzed specimen. We won't see the nuclear details or the cytoplasm or whatever the tissue or nothing. It's like a putrefied thing, which is very foul smelling for us to experience at the lab. And so there should not be any gap between the time of the surgery or the taking out the specimen from the body and putting the fix. So the gap should be minimized in order to get the best outcome. But at the same time, in other countries, the usual practice is to send the samples, some of the samples, fresh to the pathologist. If you are going to do it here, what you have to do is you have to discuss it with the pathologist beforehand, because there should be a person at the lab to receive the specimens and then describe the specimen fresh and then uh, slice it adequately and then put a fixative. But that is usually not practiced in this country. So what is expected from you is to put the fixative as soon as possible to the container and fill the container completely. Actually, about one third should be not filled in order to stop spilling, and the volume should be 10 to 20%, 20 times the volume of the specimen. That is the specimen, the volume of the fixative is needed. So there should be no time gap between, ideally no time gap between, or minimal time gap between the surgery and the adding of fixative.
Thank you very much, sir. As the time is short, the last question for today is how much of minimum volume of pleural effusion or peritoneal effusion we need for cytology reporting?
Actually, we can't tell a minimum, but we can give you a maximum, because the thing is, we like to have as much as volume we need. I mean, the thing is, it is unlike in the fine needle aspirations or the histology specimens, we don't get that much of cells in fluids. The number of fluids and the cells in the fluid is very much limited. So what we have to do is we have to centrifuge it and extract the cellular component and put it in the smear. That is what we do. So if the volume is higher, a bigger volume, we'll get a more yield. The volume of cells will be higher. So we will be able to comment on the things very easily. We have got a bigger volume. But that doesn't mean we need the whole thing. That means, as an example, if you do a peritoneal tap, you may sometimes get liters and liters. So please don't send us the about 3, 4, 5 liters of fluid to us. It is very difficult to handle that much. The maximum of 1 liter may be adequate. I mean the upper limit. If you in examples like CSF cytology, where you can't have that much of fluid because the patient also should live, and the diagnosis is secondary to the life. If we take all the CSF out for our diagnosis, the patient might die. So send the specimen volume which you can send, but we would like to have as much as possible. That means more the volume, the better will be the cellular yield, and the better will be the report.
Thank you very much, sir. Thank you once again for answering all these questions, and thank you for visiting us today for the Sri Academic Center, Knowledge Center, and also give us your wisdom on fundamental of the histopathology and all the things that ordinary medical officer should know. We hope to stay with you. We hope to share hands with you, join hands with you in the future also. And we hope you will join with us, giving us the lectures like today in the future also, sir. And many thanks also goes to all the participants. We encourage all of you to join with us next Sunday also with a very different and another interesting and timely topic on medicine. Thank
Thank you
you,
very much.
everyone, for joining, and thank you once again to Sir to joining with us and giving us your knowledge. Thank you very
Thank
much. Have a very pleasant day.